In this chapter, the basic concepts of epidemiology are reviewed. Epidemiology and demography are the sciences used to study population health. When you begin researching the health trends of your own community, you will be looking at epidemiological data. This data are what healthcare and disease researchers use when making decisions about population health. The same student learning outcomes will be used for these epidemiological concepts. How are delivery trends and the development of healthcare programs impacted by epidemiology? And how can ANA standards of nursing practice be used in epidemiology? Epidemiology is concerned with the distribution and determinants of health and diseases, morbidity, injuries, disability, and mortality in populations. The science used to determine the causes and outcomes of these factors is epidemiology. When researchers use epidemiology, they are attempting to determine how best to impact a disease or injury-causing agent to improve health. These epidemiological research studies have made significant contributions to the identification of risk factors, such as smoking and lung cancer. These risk factors can then be modified to affect a change in the health of populations. A most recent example is the banning of smoking in cars with children. In Virginia, this law went into effect in July of 2016. This law was implemented because in 2006, a Harvard School of Public Health study found that the levels of particulate matter found in vehicles where someone had been smoking for 5 minutes were higher than those found in bars in similar smoking studies. Those levels were also higher than what the U.S. Environmental Protection Agency described as unhealthy for sensitive groups, such as the children and elderly. The researchers in this study concluded that smoking in cars under typical driving and traffic conditions provides potentially unsafe secondhand smoke exposure. With this law going into effect, the health of the children as a protected group of the population is the target. This is an excellent example of a public health change where a law was enacted to affect public health. It may even persuade parents who smoke to stop as they recognize the damage they are doing to their children as they continue to smoke in their home. You can be sure that studies focusing on the health outcomes related to this law will be ongoing for decades to come. Children will be evaluated to determine if eliminating smoking from the vehicle environment has impacted their health as they grow into adulthood. Lifestyle changes can also be modified by understanding what contributes or detracts from health. Numerous studies have shown that modifying a diet, maintaining a healthy weight, increasing exercise, quitting smoking, and decreasing alcohol intake will decrease the risk of coronary artery disease as well as the risk for developing diabetes. This information about these modifications was obtained over long periods of time as researchers investigated individuals who had these diseases or were at risk for developing them. The studies indicated that these modifiable lifestyle changes could impact these chronic diseases and slow their progression in individuals who had already developed the disease. Although epidemiology is thought of as focusing only on diseases that have morbidity or mortality, the scope of epidemiology has changed in recent years. Epidemiology now includes investigations into lifestyles, as I just previously discussed. Epidemiology now also looks at health promotion strategies, as in what will cause improved health and prevent injuries in populations, not just in looking at the diseases or injuries. Epidemiology also is concerned with environmental conditions, such as what environments are healthy versus unhealthy. From the previous example, an enclosed vehicle filled with secondhand cigarette smoke has been determined to be an unhealthy environment. As data are gathered about diseases and injuries, further investigations into the lifestyle environmental conditions, and other factors are conducted. In this video, you will be introduced to the web of causation, a model which is used by researchers which focuses on what factors contribute to the disease and then looks for methods to decrease or prevent diseases from happening. So, contemporary epidemiology is now focusing on prevention and health promotion as well, and not just the factors that will cause disease and injury. There are two types of epidemiology. Descriptive epidemiology focuses on the distribution of frequencies and patterns of health events with groups in a population. Descriptive epidemiology is the who, where, and when type of epidemiology. It seeks to know the people affected, where the people are affected, and when they are affected. By using the epidemiological triangle, which is another concept reviewed in this video, as well as the web of causation, information can be gathered that provides insight into both the characteristics of the populations and the reasons that the groups are being affected. Descriptive epidemiology also allows researchers to compare the characteristics of who, what, and when with those individuals who are not affected. For example, when HIV first entered the population, epidemiologists investigated who was developing the disease. Then they looked at where and when the disease was being seen. From this information, they were able to identify those groups in the population who were being affected, and then they compared the characteristics of this population to groups that were not developing the diseases. From these data, they were able to pinpoint the groups most likely to develop the disease and begin a health campaign to broadcast to high-risk groups how they could prevent the development of this disease. Here is a nice example of an epidemiological study conducted in 2010 in Virginia. They wanted to know how many people in the state were living with HIV by major county or city. Notice that these totals include data from the Department of Corrections so that they could get an actual picture of who, where, and when these individuals were affected by this disease. As you can see, descriptive epidemiology sets up the questions for researchers to investigate who, where, and when populations develop disease or increased injuries. These data are then used to develop hypotheses for further study. A broad general hypothesis for the HIV example we just described might have been: there are no differences between the populations who develop HIV and those who do not. You can see that making these comparisons by differences helped researchers to understand which characteristics of the HIV-positive populations were unlike the populations that did not develop the disease. In the sequence of research, descriptive studies always precede analytical studies. Analytical epidemiology digs into the disease or injury process. This science looks into the associations or correlations between a disease and its sources. How and why diseases occur are the focus of analytic epidemiology. From the investigations into the how and why of disease and injury processes, the determinants of the disease can be identified, and then evidence can be used to develop medications, such as anti-infectives, modify unhealthy environments, such as smoke-free restaurants and bars or standing water, and focus on changing health habits in individuals. To review, the science of epidemiology has the broad responsibilities to monitor public health, respond to disease outbreaks and epidemics and pandemics by conducting investigations into emerging and re-emerging diseases. The outcomes of both descriptive and analytic epidemiology are to determine the causes of outbreaks and institute control measures. You are probably already familiar with the science of demography. This science is the statistical study of human populations with reference to size and density distribution and vital statistics. When you review research articles, the descriptive statistical data in the study are the demographics of the sample population, their age, gender, marital status, ethnicity, etc., whatever the variables of the research study are interested in. For example, here is a demographic study conducted in 2006 that shows the Hispanic population in Virginia. This study identified where the majority of this population resides in the state. Here is another example of a demographic study that investigated the rate of colorectal cancer between the years 1999 and 2011 in females by race. Can you think of reasons why these types of studies might be useful to influence the health of these populations? Demographic studies provide descriptions and comparisons of populations according to the characteristics of age, race, sex, socioeconomic status, geographic distribution, birth, death, marriage, and divorce patterns. Believe it or not, these types of data are readily available from various resources, and these resources will be very helpful to you as you begin to develop your community assessment in the practicum course. More about these resources in a few minutes. I want to review the levels of prevention in community health practice. These levels of prevention should be considered as you begin to develop your proposed interventions for the identified community nursing diagnoses you develop from your windshield survey. The levels of prevention are the main components of community health practice and should be used to guide intervention and evaluation strategies. In defining these levels of prevention, prevention means inhibiting the development of the disease before it occurs. You are already practicing or aware of these prevention levels of practice. Imagine your patients on the clinical floor and their various chronic or acute illnesses. If these individuals had utilized or had primary prevention that was available to them, their chronic disease processes might not have developed. Secondary prevention is what you are currently practicing in the acute care setting, in which you care for these patients with chronic diseases. Tertiary prevention is the follow-up care these individuals receive after the onset of disease or injury. When thinking about primarily applied to generally healthy populations, these then are the methods that will help prevent disease or dysfunction from occurring. Primary prevention targets all individuals in a healthy population and is further divided into two component areas: the general health promotion to populations such as nutrition, hygiene, exercise, and environmental protection, and the specific health promotion such as immunizations against known diseases and the wearing of protective devices to prevent injuries. In these manners, the general population who are healthy can maintain their health status, and the goals of injury and disease prevention can be met. These primary prevention strategies are less costly than treating disease and conditions after they occur. As you consider addressing the health problems in your own community based on your windshield survey data, think of how you can use primary prevention strategies to prevent healthy individuals in your community from becoming injured or developing chronic or acute diseases. Secondary prevention is the early detection and treatment of adverse health conditions. The goal of secondary prevention is to detect and treat a problem at the earliest possible stage when disease or impairment already exists. From this perspective, clinical nurses who work in the acute care setting are already practicing secondary prevention for their patients. These strategies may cure the illness that may be incurable at later diseases. These strategies may cure the illness that might be incurable at later stages, such as surgically removing an early stage of cancer, prevention of complications and disability, such as prescribing anticoagulants who is diagnosed with atrial fibrillation, or confining the spread of communicable diseases, such as identifying a patient who has HIV in order to get him on the retroviral therapy he needs, as well as to educate him on how to prevent the spread of it to others. Early detection of people with infectious diseases such as HIV, TB, sexually transmitted diseases, and other easily transmitted diseases may protect others in the community as well from acquiring the disease, and thus this secondary method of prevention for infected people becomes primary prevention for their potential contacts. This level of prevention is focused on the number of individuals in the population who have disease states already. Think of ways secondary prevention can be used to address any health problems you discover in your own community. The last level of prevention is tertiary prevention. This level of prevention is employed after disease or events have already resulted in morbidity or a developed disease state. The purpose of tertiary prevention is to limit disability and to rehabilitate or restore the affected people to their maximum potential capacity. Think of ways your own clinical patients use tertiary prevention to restore them to their maximum level of health once they are discharged from the hospital. They may continue to rehabilitate through physical or occupational therapy. They might need to visit lab services for monitoring of their blood levels for certain medications, such as Coumadin studies, cardiac or stroke rehabilitation, or even support groups for recovering alcoholic and drug users. How can tertiary prevention be used in your own community? The overall goal of all these intervention levels is to prevent the progression of disease and injury processes, which will potentially maximize the health of the community. Let's review the descriptive measures of health. We have already talked about demographic measures such as age, race, gender, and ethnicity. Thinking about the social determinants of health, we can also include socioeconomic status, income levels, and educational levels as well, as these factors have been shown to impact an individual's health. As you assess your own community, you will want to consider the demographics and how these factors have impacted the health of the community, as well as how these factors can be used to improve the health of the community. Morbidity and mortality are measures of health in relation to illness and disease. Illness is morbidity, and death is mortality. Illness and death rates can be very useful in looking at epidemiological data to understand the trends of health in communities. You can easily access these data for states and certain select cities in the Centers for Disease Control and Prevention's Morbidity and Mortality Weekly Report at this web address. The web address is found in your textbook on page 32. This informative website is updated weekly and contains many useful descriptive measures of health. Incidence rates are used to describe the number of people in a population who develop the condition during a specific period of time. For example, health departments and the CDC are very interested in assessing the incidence rates of Zika virus across the country as they try to determine what areas are at highest risk for developing this disease. Incidence rates measure the rate at which people without the disease develop the disease during a specific period of time. So this rate measures new cases of the disease in the population. Would you imagine the Zika virus incidence rates would increase or decrease during the summer? How about the winter? Here is an incidence rate graph that shows the Zika virus across a population by age for the month of June 2016. Epidemiologists will use this type of information to compare it to incidences in other time periods, such as winter months, and also use it to compare to other geographical areas to determine if the incidence rates are higher or lower than in other places. They can then make decisions about health and prevention for the public. Prevalence rates refer to the total number of people in the population who have the condition at a particular time. These are individuals who already have the disease. This rate can be thought of as a one-shot, cross-sectional, or retrospective study. Prevalence looks at the extent of morbidity or disease in a community. Obviously, this rate is impacted by the rate of new cases or incidences, any effective treatment modalities, such as immunizations, and deaths in the population. Here is a prevalence map that illustrates the presence of Zika virus in the United States, dated May 2016. Notice how the border states, such as Texas, California, and Florida, have the highest prevalence of Zika at that time. What do you think are some reasons for these states to have the highest numbers of infected individuals? Will your community be at risk for the development of this disease? How can the levels of prevention be used to affect this disease in populations? The final descriptive measures are are ratios, proportions, and rates. I'm not going to go into specific details about these, as we have already reviewed incidence and prevalence rates. For the purposes of your activities in this course and in the practicum course, these incidence and prevalence rates should be the only ones you need to research in order to develop an understanding about the health of your own community. Rates are very useful in order to assess the probability that one group is at higher risk than another, as they measure the amount of disease, disability, or death within a unit of the population and within a unit of time, say a quarter, a month, or a year. Rates improve the ability to make comparisons because they reduce the standard comparison to a common denominator, which is the unit size of the population. In other words, as you research your own community, you might want to compare your community's incidence and prevalence rates with those of a community that has the same demographics and size as yours. If your community has higher incidence and prevalence rates of certain diseases or injuries as compared to the community with similar demographics and size, you can then make an educated judgment about the reasons behind these health problems. This will then give you a focus for developing your community nursing diagnoses and intervention strategies. Box 3.1 on page 35 of the textbook provides you some commonly used rates. While you may not be using all of these forms of rates for your own community assessment, the definitions of these rates will be helpful as you review the data relating to your own community's demographic information. There are many resources of community health data available as you begin to research your community's health. The first place to begin might be the census. This is probably the most comprehensive source of health-related data for the United States. Every 10 years, the Bureau of the Census counts the country's population and surveys it for its basic demographics. The census data provide a wealth of information about a community's characteristics, such as age, race, and gender, along with other factors such as employment, income, migration, and education. The results are reported in regions known as standard metropolitan areas. Here is a population density map for Virginia that was developed from data collected from the last 2012 census. How could this information be used to improve or address the health of the population of Virginia? Census data are available online at this web address. Vital statistics are other sources of community data. These data describe legally registered events such as births, deaths, marriages, and divorces. The CDC's National Center for Health Statistics collects and publishes vital statistics from individual states. You can use these data to examine trends over time and to help you develop intervention strategies. For example, what if you notice a trend for births in your community begin to increase exponentially in teenage adolescents? Could the levels of prevention be used to address this health and social issue? The data relating to vital statistics are available at this web address. Notifiable disease reports are also excellent sources of population data that relate to health. These are data collected by state and local health departments on legally reported diseases, such as communicable diseases. These diseases must be reported, as health organizations such as the CDC require notification of certain diseases. Criteria to determine whether a disease is notifiable are the ability of the disease to cause death and the communicability of the disease. Notification to public health officials of disease posing a threat to a large population provides an initial starting point for local epidemiological investigations, and the Morbidity and Mortality Weekly Report mentioned earlier is the best place to find these data. The last resource of health data you might find useful is the National Electronic Disease Surveillance System. This Internet resource provides an integrated surveillance system that transmits public health laboratory and clinical data via the Internet. The process improves the nation's ability to identify and track emerging infectious diseases and potential bioterrorism attacks. You can find information about your own community's disease trends at this web address. As in other sciences, epidemiology uses models to guide investigators in examining the determinants of population health. We will review 3 of those models: the epidemiological triangle, the web of causation, and the social ecological model. Each model provides a unique perspective about how health and illness are affected, and these models are often used concurrently when investigating the health of a population. The epidemiologic triangle is probably familiar to you. This model is a traditional view of health and disease. The agent is an organism capable of causing a disease. The host is the population at risk for developing the disease. The environment is a combination of physical, biological, and social factors that surround and influence both the agent and the host. The epidemiologic triangle is used to analyze the role and interrelatedness of each of these factors. The textbook gives an excellent example of how this model can be used to understand and investigate infant mortality. Here, I want to use the model in relation to understanding the factors that lead to HIV infection. We could begin at the lower left corner of the triangle, where the agent is identified. But look at the various factors that influence the agent. Which form of HIV is causing the disease? Is it one of the viruses that has antiretroviral resistance? How could this impact the triangle's interactions? Next, look at the top of the triangle at the host. There are many factors that influence the host in this relationship. The host's genetics, the stage of infection, the antiretroviral therapy prescribed, and other factors will affect the way that the host manages this disease. Some factors are modifiable, such as the stage of infection or access to drug therapy. This is where primary and secondary prevention play a role. But many of these factors are non-modifiable, such as genetics and pregnancy. The final corner of the triangle is the environment. Various factors play an important role in this interrelationship. Social norms relating to this disease are very strong. The stigma associated with disease may impact the host. The social and economic determinants of health or risk behaviors also have a large impact on the host. Is the individual able to work and therefore have a steady income and health insurance so he or she can afford the antiretroviral therapy? And what type of work does the individual perform? Would someone infected with HIV be able to work in a job that required heavy labor, or would that impact their health as well? How about social support? Does the individual have family or friends who are aware of their disease process and offer unconditional support? This example of how the epidemiological triangle can be used to understand disease and health states considers all these factors as related and important in the development or resistance of disease or injury. The web of causation views a health condition as the result not of individual factors, but of a complex interrelationship of numerous factors that interact to increase or decrease the risk of disease. This web attempts to identify all the possible influences on the health and illness process. Creating the web identifies the most direct causes of conditions, factors contributing to those causes, factors influencing each of these factors, and so on. As you can imagine, a web of causation can become very detailed as more layers are added to the web. One of the most important concepts in the web of causation is the concept of synergism. This is a concept that states the whole is more than the sum of its separate parts. Because this model is complex, it is difficult to carry out in everyday practice. But by examining one portion of the web, sufficient information for developing levels of prevention to improve community health can be found. Here is an example of a basic web of causation for the major cardiovascular diseases. One of the first things to notice are the presence of multiple arrows leading to and from each factor. Starting at one factor and following it to the outcome of coronary heart disease can help you to understand these complex relationships. Let's start with an obvious factor, diet, at the very top right. Diet can lead to many other factors, and in this case, let's follow it to salt. Salt then leads to hypertension, but note that hypertension is a factor that is influenced by other factors such as heredity, physical inactivity, and stress. It is also affected by atherosclerosis, which itself is influenced by heredity, hyperlipidemia, hormones, fat, total calories, and diet. So the disease of hypertension can be influenced by all these factors, which then can lead to myocardial infarction. Death in the cardiac tissues can eventually lead to coronary heart disease. So, this intricate web of causation for coronary heart disease is influenced by many factors, both modifiable and non-modifiable. But in looking at these factors, health professionals can determine where interventions can occur that will disrupt the web and influence the development of this disease process. The last model to review is the socio-ecological model. This model views health and wellness and disease as the result of interactions of factors at different levels within society. The social title does not refer to Facebook or having a few drinks with friends. It refers to society as a whole. The ecology of the model refers to the study of organisms and their interactions with other organisms and their environment. The layers interact to influence the individual, who is at the center of the model. The individual at the center comes with traits, behaviors, and a past history. The individual is influenced by the outer layers. The next layer is the microsystem layer. This layer includes the people and environments that influence the individual and with which they have the most frequent and direct contact. This might include the household, school, workplace, or other settings such as a church or a club. The individual's risk for death might decrease due to interactions at the microsystem level. The next layer is the exosystem. This layer includes factors that influence the microsystem in which the individual is functioning. The individual does not have direct contact with the exosystem, so this influence is indirect but still impacts the individual's health. An example of an exosystem layer here at Centera is the requirement for all employees to receive the flu vaccination once flu season begins. This exosystem factor is designed to keep all Centera employees from getting the flu, as well as prevent all of Centera's patients from catching the flu from its employees. You have no direct influence on this policy, but your choices are either to receive the flu immunization or to wear a mask during flu season. The final layer is the macrosystem. This layer is the most broad, which encompasses cultural values and beliefs that influence the exosystem, microsystem, and individual. This layer includes public policies, economic conditions, and history. Cultural norms, socioeconomic status, and ethnicity are all found at this macrosystem level. Here is a nice illustration of the social ecological model. Notice how the layers are interactive and can diffuse into one another. This means that the layers are all influential and press onto an individual's health. Here is an example of how this model can be applied to a health problem. The influence of obesity is the focus of this social ecological model. At the center of this model is the individual, who is influenced first by the family, the genetic traits, the family behaviors, and the history with the family which begins at birth. Does this individual possess genes that tend to increase the risk for obesity? Does the family tend to promote unhealthy diets and discourage physical activity? Is the individual monitored for these risks from an early age? The next layer are the behavior settings. This microsystem level includes the home, childcare, school, work sites, and community and faith-based settings. What types of meals and snacks are provided in these settings? Does the school have a program for healthy eating and physical activity? Does the community offer resources that will promote healthy eating and physical activity? How about social settings like churches and clubs? Do these settings promote healthy behaviors in relation to obesity? The sectors of influence include what food systems are available, the built environment, transportation options, etc. This is the exosystem level. For example, does the individual ride to work in a car, or are there opportunities to bike or walk to work? In the built environment, are there bike or walking trails? Is the distance to the grocery stores too far to travel by bike? How about the food options that are available? Does the individual obtain their food from a store where fresh fruits and vegetables are available, or are these foods scarce or highly priced? The final layer of the macrosystem includes public policies, advocacy, and media. Are there communication or advertising resources that inform the individual of healthy options? Are there policies enacted that might influence the individual in relation to healthy eating or physical activity? Are there groups, such as support groups, that may advocate on behalf of the individual's health? You can see that from this model, there are many layers that all converge on the individual to influence their choices and resources in relation to their health. This model demonstrates that there are no distinct causes of diseases or injury, but there are many interrelated factors that influence each other and the individual to set up a perfect storm for developing disease or becoming injured. This finishes the last video for this week. There was a lot of information presented this week that should help you get started on your own windshield survey and community assessment. In this video, the levels of prevention, epidemiological concepts, descriptive epidemiology and demography, the models of health, and the web of causation, including the epidemiological triangle and the ecological, social ecological model of health, should help you to describe the evolving social, cultural, and healthcare delivery trends as you develop healthcare programs for the aggregates and communities. How can you use these concepts to understand the healthcare delivery trends in your own community? Using the ANA Standards of Nursing Practice and applying these concepts is an unstated rule as you work with the population to improve and influence their health. For example, confidentiality in the epidemiologic triangle is a standard of nursing practice that must be upheld even with working with individuals in the community. These student learning outcomes can now be applied as you begin to work on your own windshield survey.